Hi, my name is Eric Wise. I'm currently a minimally invasive surgery fellow at the University of Minnesota in Minneapolis. I did residency just up the street here at Maryland. I thank everyone for the privilege to present here at SAGES. The title of my talk is Prediction of 30-Day Morbidity After Sleeve Gastrectomy, Data from an Artificial Neural Network. I have nothing to disclose. As a brief introduction, preoperative, intraoperative, and postoperative factors, as well as predominantly random chance, govern complications after bariatric surgery. The National MBSA QIP database, which we've discussed fairly extensively this morning, sufficiently comprehensive to answer critical questions in bariatric surgery, as well as change the practice. In the 2016 data set, which was taken for this study, there were over 186,000 cases from almost 800 centers. In addition, specific post-bariatric morbidity and mortality of interest, as designated by the MBSA QIP, were 30-day readmissions, reoperations, reintervention, and mortality. So the aims of this study were first to identify simple preoperative patient factors that may portend an increased risk of 30-day M&M after laparoscopic sleeve gastrectomy, but more pertinently, we wanted to optimize the predictive ability of a panel of readily obtainable, easily quantifiable preoperative factors and maximize the variance that's contained within those variables to predict the outcome of 30-day M&M, understanding that much of it's governed by random chance and intraoperative and postoperative factors. So to back up a bit, I want to talk a little bit about artificial neural networks, which is basically machine learning. This technology was developed in the 1960s to simulate physiologic neural systems, that is, the brain. Predictive applications thus far have been in the realms of defense, fluctuations in stock market, speech recognition, among others, and there's been some limited use in clinical medicine. The benefits of artificial neural networks are primarily that there's improved accuracy, sensitivity, and specificity relative to traditional models which we use in clinical medicine all the time, which are almost exclusively based on multiple logistic or linear regression, depending on what your endpoint is. And therefore, with a neural network, you can ask or re-ask any clinical question, novel or not novel, with a new approach. So features of a neural network algorithm, to keep this as simple as possible, there's an input layer, which in our case would be preoperative or any factors that you designate as predictive of an endpoint. And then you teach the model how to predict. And the teaching is done at nodes, which simulate brain neurons. And then there's an output layer, which is the one response, is there going to be an event or not in this case. And these models are internally validated with a training and a validation set. So 80% of the patients, in our case, would be trained or would be used as to constitute the training set to develop the neural network algorithm. And then 20% of those patients would be randomly withheld to ensure that there's internal validation. You didn't really overfit the model from those 80% of the patients. And then neural networks generally use backpropagation. That is, you teach the model one thing, it realizes its mistakes, goes back and relearns, and that's backpropagation. There's been some clinical examples of neural networks. A few representative examples include prediction of mortality after amputation, prediction of prompt extubation after a coronary bypass, and prediction of survival after aneurysm repair. And these models are compared to traditional logistic regression prediction models or linear regression prediction models and have shown to be better. Its clinical usefulness remains to be seen. So for this study, again, we wanted to optimize the variance that's contained within simple preoperative factors for outcomes after sleeve gastrectomy. So we were able to whittle the patients from the MBSA QIP dataset down to about 100,000 patients who underwent multi-port sleeve gastrectomy. And then a priori, we chose a panel of preoperative factors, primarily based on simplicity. We chose demographics, the main comorbidities, which had a high prevalence, as well as a couple of very specific other preoperative patient factors, again, that were known before surgery. And the endpoint that we used was a validated endpoint, actually, a 30-day morbidity and mortality composite endpoint that constituted 30-day readmission, reoperation, reintervention, and mortality. And then we used those factors that we found were predictive of our endpoint and did a neural network model and a logistic regression model to see which one had a better goodness of fit. So the variables here are listed on the left. Again, we use demographics, two principal comorbidities as defined by the MBSA-QIP, as well as functional status and whether it was revisional surgery, with our composite endpoint shown below with a rate of approximately 4%. We then performed bivariate and multivariate analyses to see which of those, among those 8 variables, were predictive or were significantly associated with our 30-day endpoints. And of these 8 variables, 7 of them were statistically significant. Whether they were clinically significant, that's another question, but 7 of the 8 were statistically significantly associated with a 30-day M&M, gender being the only one that was not. So higher age and initial BMI, non-white race, as well as the presence of hypertension, diabetes, non-independent functional status, and revisional surgery, as makes logical sense, were all predictive of 30-day M&M. And then we were able to, we used a traditional multiple logistic regression model, which came up with a reasonable area under the curve of 0.572, which translates to about 14% of the variance of whether there's going to be an event or not is able to be contained within those preoperative variables. With a 7-variable neural network model with 3 training nodes as diagrammed on the left, we did a little bit better. About 20% of the variance was able to be contained from those factors using a neural network model to predict. And I haven't shown the ROC curve here, but this is the ROC curve from the 80% training set. The 20% internal validation set actually had an area under the curve of 0.582. Certainly, there's plenty of limitations to this small study. There was a selection bias inherent in using retrospective data collection. Again, there's only a small amount of variance that's contained within these preoperative factors, and we know that there's major factors that were not considered, whether they had a concomitant cholecystectomy at the same time, who the intraoperative assistant was. And the biggest limitation in using neural networks clinically is the fact that they're algorithmically complex. There is an underlying algorithm that's developed, but nobody understands it, whereas regression coefficients are used from multiple logistic regression are used in clinical medicine all the time, where every score, we actually saw some of this morning, every risk factor adds 1 point or 2 points, and those are just regression coefficients of the regression expression. So it's a black box model. In the past, we've had some success translating neural networks into something that's clinically useful. A couple years ago, we were able to take 5 factors that we found to be predictive of weight loss after gastric bypass, and we developed an online web-based tool whereby patients can input their information in a table, and they were able to get an optimized, using a neural network algorithm, an optimized estimate of their weight loss at 6 months and 1 year. So there are ways to translate neural networks clinically, and it's something I want to continue to work on. But obviously, I think that's its biggest limitation. It's lack of understanding and accessibility to clinicians. So in conclusion, here we show a panel of demographics, comorbidities, and patient factors that were indeed predictive of 30-day M&M after sleeve gastrectomy. The predictive ability of the variance attributable to these risk factors can be maximized using neural network algorithms and neural network methodology, machine learning methodology. But again, the biggest limitation remains clinical accessibility, and there are ways around that, but certainly it's not a straightforward modeling technique, and there's a lot more to be researched with respect to neural networks. Nonetheless, I really appreciate your time and letting me be here and talk about this topic, which I really enjoy. Thank you very much.